COVID-19 update. The continuation of this update will be divided into Part 2A for treatment and Part 2B for vaccines. So let's move on to treatment. Unfortunately, what was touted as potential benefit when viewed through scientific study ended up not being as promising, including convalescent plasma, fluoroquinolone, remdesivir, and then we'll discuss ivermectin in just a second. For those who are hospitalized, dexamethasone has been shown to improve survivability. We'll then move on to monoclonal antibodies, a new pill from Merck called Molnupiravir to treat those that have COVID, and then finally Fluvoxamine, which is an antidepressant that is showing some promise in the treatment of patients with early COVID symptoms. We know that most treatment will affect either one of two processes. One is actually inactivating the virus by attaching to the spike protein, and the other is decreasing the amount of inflammation associated with the infection. We do know that those that are naturally infected have antibodies also to the nucleocapsid proteins, which cannot be conveyed by the COVID vaccines, which are specific to the spike protein. Low levels of vitamin D were found in the chronically ill and seniors, which then predisposed people to more severe disease. Quote, the weak response of the innate immune system in the elderly may increase viral load, and a shortage in memory B cells leads to a misfiring and overactivation of the adaptive immune system by producing a high level of cytokines or a cytokine storm, unquote. Vitamin D may suppress cytokine production by simultaneously boosting the innate immune system and avoiding the overreaction of the adaptive immune system to immediately respond to viral load. Some proposed actions of vitamin D are that all cells have vitamin D receptors, including macrophages and helper T cells, but in the respiratory tree, and remember SARS-CoV-2 is a respiratory infection, there are in the sinonasal epithelium vitamin D receptors which activate vitamin D. It also upregulates cathelicidin, an antimicrobial protein made by humans, which has antiviral, antifungal, and antibacterial properties. Let's move on to ivermectin. This is an antiparasitic used to treat river blindness, strongyloiditis, filariasis, etc. It affects nerve and muscle cells in invertebrates. It causes opening of chloride channels leading to hyperpolarization, leading to paralysis and death of the invertebrate. So the data on ivermectin is confusing. So does one err on the side of caution? Well, this systematic review, consisting of 10 RCTs with over 1,000 participants, found that half the studies used usual care as controls and half used placebo. Ivermectin did not reduce all-cause mortality or length of hospital stay. Yet in this systematic review, in 11 RCTs, there was a 56% reduction in mortality with reduced time in recovery and reduced time in the hospital. The problem is, many of these studies were not peer-reviewed and use a wide range of doses. In pharmacokinetic studies that test at the highest tolerable dosing, those levels remain too low to have a direct therapeutic effect based on in vitro studies. So without support for a potential mechanism, it's difficult to see how ivermectin could work, yet some studies indicate that it does. Remember, there is a difference between veterinary ivermectin and human ivermectin. These last two more recent published RCTs do not report a benefit. This included a Colombian study that randomized 476 adults. There was no significant difference in the time to resolving symptoms between the groups, and symptoms resolved in 82% and 79% in the active versus the placebo group, respectively. A second study from Argentina randomized 501 patients to ivermectin or placebo in a staggered dose, according to weight, for 2 days. There were no significant differences on the primary endpoint of hospitalization in ivermectin versus placebo. Next, monoclonal antibodies. What are they? They are made by manufacturing clones of B cells targeted against the spike protein. They can have monovalent affinity binding only to the same epitope, the part of an antigen that's recognized by the antibody. They are effective for about 1 month. So clinical trials have shown that Regeneron's monoclonal antibody treatment, a combination of two monoclonal antibodies, reduces COVID-19 related hospitalization or deaths in high-risk patients by about 70%. And when given to an exposed person, like someone living with an infected person, monoclonal antibodies reduced their risk of developing an infection with symptoms by 80%. Recently, there is some evidence for a pill for COVID, Molnupiravir. Studies were started in 2019 as an alternative for the treatment of influenza, a prodrug that, when metabolized to a ribonucleoside analog, which substitutes cytidine, it causes replication errors in RNA transcription. The first tests were in animals, then in humans. The drug is taken 2 times a day for 5 days. In this study, efficacy and safety of Molnupiravir in non-hospitalized adult participants with COVID-19, Merck stated that an independent advisory board had been monitoring the COVID-19 trial and recommended that recruitment into the trial be stopped early because of convincing evidence of the drug's benefit, reducing the risk of hospitalization or deaths by 48%. In this study, there were approximately 700 individuals worldwide. Qualifications included having mild to moderate disease, not hospitalized, unvaccinated, at least one risk factor for severe disease, sick for less than 5 days, a positive PCR test, and the variants studied 80% of the time were Delta, Mu, and Gamma. The results indicated that 7% taking the real drug were hospitalized but did not die. For the placebo group, 14% were hospitalized and 8 died. Independent groups studying the trial decided to stop the trial because they felt the drug was effective, so giving people a placebo would be considered unethical. Time will tell whether this drug proves to be beneficial. And finally, Fluvoxamine. This is an antidepressant. In fact, it's a serotonin reuptake inhibitor. So why would this work for people with COVID? The belief is the mechanism of action might be a secondary effect of this drug, which is to bind to receptors that will decrease inflammation. So they believe the effect has much to do with cytokine storm inhibition. Participants were randomly assigned in this first study to receive 100 milligrams of fluvoxamine 3 times a day for 15 days. Clinical decline occurred in 0 to 80% in the fluvoxamine group and 6 of 72 patients in the placebo group, the absolute difference being 8.7%. In this second study, treatment with fluvoxamine among high-risk patients with early diagnosed COVID-19 reduced the need for hospitalization, defined as retention in a COVID-19 emergency setting or transfer to a tertiary hospital. The proportion of patients observed in the hospital room setting for more than 6 hours or transferred to a tertiary hospital due to COVID-19 was lower for the fluvoxamine group compared with placebo. The question still remains, what is the mechanism of action, and further studies are needed.